First, I want to give respect to people who came before me. I'm a member of the Lummi Nation here in Washington State, and my Indian name is Siagwik. I'm honored to carry the name of my great grandmother, Ada Descanum. And I'll keep it short because this could take the whole presentation to introduce myself. But I do want to acknowledge and give prayers to all of you that are surviving and hopefully thriving beyond the wake of Hurricane Ida, and all of our relatives who are still suffering at the hands of this pandemic that's having another big surge. And I just want to start the morning acknowledging that the world is still suffering. And this is not the first pandemic that our communities, our people have lived through. We're going to make it through this one as well. And our resilience and our cultures and our communities are going to be the force that helps us get through these trying times. So good morning. I'm about a half hour north of Seattle at my home. It is actually 6:20 in the morning. Yesterday morning, I got up at 4 a.m. because I'm on Pacific time, thinking I had to do this presentation, and I got everything ready. It was today. So I had everything ready. Here, I'm going to share my screen. And I have quite a few slides. I kind of added too many, knowing that I'm not going to get through all of them. And I would love it if you guys just feel like unmuting yourself and saying, hey, I've got a question, please do that. I can't see you because I'm watching my screen. Can you see the screen?
Not yet.
No. Okay. That's because I didn't share it yet. Hold on. I'm getting there today. How about now?
Yes.
Okay. Okay. So, yes, Rose James, the Urban Indian Health Institute, and I'll just quickly go through some of the orientation slides because I don't know who in the audience knows who we are or what we do, but we're a tribal epidemiology center. We're one of 12 across the country and the only one that serves urban American Indians, Alaska Natives. And our parent organization is the Seattle Indian Health Board, which is a clinic grounded in traditional medicine, downtown International District of Seattle, and a federally qualified health center. So we serve over 60 urban American Indian, Alaska Native serving organizations across the country. That's where we're located. Here are the other 11 tribal epicenters that are representing federally recognized tribes, primarily in Indian Health Service regions, geographic regions across the country. And tribal health epicenters were started back in the 90s and established via the Healthcare Improvement Act. We're a public health authority, so we have that status with Health and Human Services and access to HHS data systems and protected health information for the most part. I'd say it's not as simple as that. We can't, it just seems like it's harder to get access to our own data for our own people and communities so that we can do the health reporting and supporting them so they can make informed decisions about serving our communities. It's harder than it should be. Urban Indian Health Institute, established in 2000 as a division of Seattle Indian Health Board, and our mission is to support the health and well-being of urban communities. And Seattle Indian Health Board is a clinic that is integrated into a primary care clinic with behavioral health, et cetera. Let's stop here for a minute. I want to tell a story today that as this presentation unfolds, this story, it starts with a young Tlingit mother who leaves her home, her culture, her community up in rural Alaska, and she relocates to Seattle. Promise of jobs, education, and other things that are lacking in the area that is her homeland are what moves her and relocates her to a metropolitan city. With that, I'll pick that up again in a minute, but I wanted to start with that baseline foundational part of our story. So when we're talking about what does decolonize data mean, it means a lot of things to me, but I have to start first with why we have to decolonize data. And to do that, we have to acknowledge and pay respect to the fact that our ancestors have survived many, many plagues, many assaults in the name of policies by the federal government, by states, and colonizers. So back in the 1700s, there was a general, Jeffrey Amherst, who advocated for the use of smallpox to purposely gave our tribal leaders and tribal people infected blankets with smallpox. So when I say we've survived pandemics before, we literally have. And that wiped out so many of our people, over 50% in some tribes or entire tribes. The late 1800s, the Gila River was cut off and diverted from the Pima Indians and rerouted to farmers, colonizing farmers upstream. So basically forcing the Pima Indians to relocate. In the 60s and 70s, there was an express policy of the US government. This is known as the sterilization era that I have certainly heard about through people I know versus what I've read in high school textbooks, because it has all but been erased from our written history in the country. It is certainly something that I find many people are not aware of and have never heard of, because like boarding schools, it has not been something that has been taught in our schools. And with that, it's that omission. The country and many people who are not hearing, who are not learning through their relatives like we do about our own true history, conveniently forget, but it is in our communal memory. Research has long been a part of Native communities, and I want to point out that all this time, long before 1700, since time immemorial, Native people have been doing research. We wouldn't survive today. We wouldn't be navigating the Salish Sea out here in the Northwest if we weren't engineers. We have always been observers and geneticists that created the first corn that was nutritious and edible out of a basically crossbreeding this grass. until it became something that we could plant and cultivate. So I want to acknowledge that this is this timeline is a story of just a few highlights of some of the more catastrophic elements of intersection with colonization that set the stage for why we need to decolonize data. But it's not that we as Native people have not been supporters and actors in conducting our own research. In 1970s, there was an alcohol study with Alaska Natives in Barrow, Alaska, that basically they reported this in the news, and headlines were saying that this Alaska Natives were all alcoholics and would soon be eliminated based on that disease. It caused a lot of stigma. So research has been used in ways that have not benefited our communities and many times have been harmful. And then one of the more recent ones, the Havasupai tribe, agreed to do genetics research with a university in Arizona, but it was on type 2 diabetes. And as is the culture of lab sciences, I have a doctorate in pathology, so I was a lab rat for many, many years. In that culture, you share samples. Samples are hard to get, especially American Indian or certain minority underrepresented populations. And these samples were shared with other labs without the knowledge or consent of the tribal leadership of the Havasupai. They used it to look into other things that they did not ask explicit permission, such as inbreeding and things like that. So this resulted in the tribe really aggressively going after the university and those researchers, and they did eventually get their samples back, but it also resulted in a moratorium on research, which is too bad because that ripples throughout Indian country. I spoke about that. I also want to acknowledge that these assaults on our communities were intentional. The boarding schools are something, again, we have heard a lot about in the news. I don't know about many of you, but I have certainly had a number of people say that they had no idea that there was a boarding school era, that Native people were removed from their families and their homes, their cultures, and their communities as young as 3 years old during this era. And they were sent to boarding schools here in the Northwest. For example, I have relatives who were sent forcibly to Chemawa in Oregon. Fran James, who's quoted here, was my great aunt. So that's how I know about these things. And those communal memories are part of what make us who we are today in many ways, but it also feeds a mistrust of the federal agencies and outside organizations and groups that want to do something with us, that like education and support us in education, but through their institutions. Boarding schools were they were designed to assimilate, to kill the Indian and save the man. So exploitation has also been a hallmark by biomedical research. There's bioprospecting and degradation of culture and forced assimilation. A lot of Native people in Alaska, I heard they called it helicopter research, where they take your blood or your information and then you never learn the outcomes. There's no tangible benefit. We're trying to reverse that. We're trying to reclaim what research does as a tool for us. And academic partnerships in research have also caused trauma in the name of knowledge for the greater good. So there is a lot more movement among tribes and urban organizations to increase the control over the research process. Maybe even be the researchers that are leading that process and designing the research questions that matter to our communities. I talked about that. I also want to acknowledge that it's not just Native communities that have these memories of biomedical research and events that have happened that have shaped even our lives today. In 1955, Cutter Laboratories created a vaccine for polio that was faulty and children died due to it. So that memory is actually coming back in, and it fans the fuel of a lot of our anti-vax movements even today. But the process of creating vaccines has really refined. Our job now as a public health authority is to convince people that these vaccines are safe and they are effective. And quite frankly, unfortunately, now I've got to tell people not to use horse medicine. Never thought I'd have to say that. I want to acknowledge that when going into this next section, that we are in a place where we talk about data, we talk about what are the statistics of American Indians, Alaska Natives, let's just say around heart disease or domestic violence. You can pick any of the above. Who has tested positive for COVID, who has succumbed to hospitalization, who has survived COVID. When we talk about that kind of data, it's coming from places where it's collected by the state, or it may be collected by CDC through surveys. There are a lot of challenges to the data alone that we acquire and we analyze and report on, and reporting on those limitations is incredibly important, so people understand that what we find and what we're reporting on has flaws in it. Usually those flaws have to do with an underreporting of and missing data around American Indians and Alaska Natives. We're a small population, so we often are not, when you look at the bar charts and they're talking about COVID, for example, they have, here's non-Hispanic whites, here's African Americans, here's Latinos and Hispanics, and the Native people. That was too small. So they're not statistically significant, but we are, and we need to find ways to work with small populations, because when we look at the data and are able to disaggregate and look at the American Indian, Alaska Native experience, we typically are represented disproportionately with disparities. There's racial misclassification. When somebody is diagnosed with something like COVID, there's not really data there that even shows what race you are. And certainly if you're multiracial like myself, when the data gets analyzed, and I check American Indian, Alaska Native, and white, and my mother is from Central America. So I'm Latina and I check that. I get lumped into Latina. So I essentially become erased. And that happens over and over and over again. It's not just American Indians. It's most of the population of this generation is mixed race. And we get collapsed into a category called other. So how do we address small populations? You need to have a standard and accepted and inclusive definition of what American Indian and Alaska Native is. You need to aggregate data across time or geography in order to collapse that data so you have enough to do statistical analysis. So I guess the point of these next few slides is there are ways to address this. The practice and the policies aren't there at federal agencies like CDC or your state Department of Health. They all do things differently. And our public health infrastructure, even long before this pandemic started, has always been fragile and sorely underfunded to address some of these problems. There's limited data sets that contain both race and ethnicity, geographic data at the level needed. Difficult to identify variability in the population health linked to geographic. So consider creating a supplemental report specific to Native people. It's about time that we were highlighted and not overlooked. Again, omission is a systematic way of eliminating a population. Omission from history books, omission from the data, omission from the reporting. And when we collect data at the state level, federal level, local level, et cetera, even here in Snohomish County where I live, I don't know that they've ever specifically done surveys of health indicators specifically for American Indians and Alaska Natives, because they certainly haven't asked me. And I live right, I can walk to the public health agency here. So why is that? Well, if you ask me, a large part of it is that we need to be doing this data collection and analysis and reporting ourselves. As Native people, we know our communities, we understand the context of that data, and we have the dedication. We need a bigger workforce that's doing this work in public health. And there are challenges to these westernized systems that we are forced to work within these infrastructures. Sorry, I need a sip of coffee. It's early. We need to be looking at data through models of Indigenous health equity. Because these resources are directly tied to how we are presented as needing resources for cancer control, for heart disease, for addressing environmental public health disparities in our communities. And it is one area where research and data has been utilized to eliminate, to omit, and make invisible our population. So it is another form of colonization that we need to reverse. Misclassification, it masks the actual population. It masks who we are and what we're experiencing. And I'm not just talking about disparities. I'm talking about our resiliences and our strengths, we're still here today. There's a reason we're here today. Often it's because we are resilient and strong. We navigate things every day of our lives. We navigate racist structures in our institutions every day. And we yet at the same time are able to move forward using frameworks that embody our values and our cultures that have kept us strong. CDC collects data from states on COVID, positive tests, populations, race and ethnicity. The states collect those, right? Hospitalizations and other health outcomes related to long haul COVID, for example. But the states all collect that data differently. And millions of people are missing from those data sets that are reported to the states. The states are not required to submit everything, so they choose what they're going to submit to that federal data set. And misclassification or lumping into other or no race or ethnicity at all linked to this data varies dramatically. If you look at Texas, for example, there are no COVID cases, apparently, that are, and certainly none that are American Indian, Alaska Native, African American, anything like that. If you look on their State Department of Health website, you can see that information, but what they're submitting to CDC is minimal. So that masks us. It masks the experience of our Latina relatives and our American Indian Native relatives and the needs that we have. So let's go back to our young mother. She's in Seattle, and those jobs that were promised are non-existent. She's away from her community and her culture, starts getting into relationships that are abusive. She loses her home, and alcohol starts to play a central role in her life. She now has 3 small children. She gets into a heated argument with her partner, and she's compelled to go after him. She locks her children in the bathroom. This isn't the first time. The oldest child, who's about 6 years old, gets them out of the bathroom and takes her younger brothers downstairs to a restaurant because they're hungry. Child Protection Services steps in, and the children are taken away. They're placed in foster care. This is the era of Indian Child Welfare Act right now, which, was created to address the taking away of children and putting them into non-native, often white families, and again, a form of assimilation for many years that happened, and disproportionately our children are represented in foster care system today. But that system, even with Indian Child Welfare Act, did not, it was a broken system in the first place. And so 13 different homes, this family that they didn't want to break up, these siblings, they went through 13 different homes. There was abuse of every kind that happened at different places, and a disconnect, not being able to bond with anybody but themselves and their mother, who continued to see them in between bouts of homelessness and treatment. Okay, back to the data. What do we do? What does decolonizing data look like? Data is everything. It's not just data sets. It's not just counts. It's our stories. Our stories are data. Our stories are what have helped us understand the true history of our communities, and our stories have kept us resilient and strong. This is an example of something that we're doing as a evaluation core with the Seattle Indian Health Board. This is a COVID resource map that we created using ArcGIS, interactive online platform. And one of our evaluators worked with the homelessness investment outreach person who put together a whole spreadsheet and said, this is where all of the hand sanitization as well as places you can shower are in the King County area. Here's the address, here's the hours, here's food pantries. And she would go out every week and make sure that was all accurate, because test sites for COVID were popping up everywhere and then they'd shut down, right? And it's constantly changing. So she did all that on boots on the ground work. What Daisha, our evaluator, did was map that into this interactive map. And now our providers and people on the clinic side, when our relatives who are our patients walk in the door, and we're in an area where there is high opioid use, we have an epidemic here of homelessness, and people are just giving them, here, this is where you go to find clothes because you have a job interview. We're able to download that and show them exactly where to go for the different resources that they need. That's decolonizing data. It's using data that's collected by with the love and dedication of our own people and our own community, and the interests of our needs of our communities in mind, and putting it into tangible utility. So as one of the testimonies of this, for this particular tool, one of our relatives came to the clinic looking for supplies like a tent and hygiene bag, and he had not been able to take a shower for a while. He only knew about one hot meal center. He didn't have a phone. He didn't know the area well, so you couldn't tell him just go down to Pioneer Square. So the homelessness investment outreach person asked him where he was staying, and was able to print out a map of all the hygiene stations and the food banks. Another relative came in looking for shelters, and he was going to be moving to another encampment further south. He was worried about where to find food and where to shower, and working with the map, printed out routes that highlighted how to access these resources where he was going to in the other area down south of King County. And they were able to, when the next time he came in, he was in a place where he was ready to get clean and look for sober housing. So meeting your relatives where they're at, that's decolonizing data. I'm going to speed past these, but putting the power of Indigenous evaluation of our programs that work with youth, for example, in the hands of our urban American Indian, Alaska Native serving communities and programs, that's decolonizing data, because that data guides your program, but it also guides your youth, and it's a way of empowering our own people and our communities. I know we're getting close, so I'm going to speed to the end here. Community needs assessment. Community needs assessment, but also what do you do with that? When you identify the needs of your communities, you identify the assets and strengths, recognizing that Western models of data collection, whether it's surveys or research study designs, they often focus on the negative, on deficiencies. Why don't we look at our strengths and our resiliencies? When we're talking about suicide prevention in youth, there are some real promising, amazing, effective programs out there that are working, and at the center of their work are things that are directly taken from our culture and our values as Native people, such as talking circles. So let's go back to our story. This is a picture of traditional foods. Where you're at is going to be different than where I am. For us, we're part of this. Our relatives are the salmon. We're the salmon people. And coming back to our cultures has been a movement, and our foods as our medicines has been a movement that I have seen taking root here in the Northwest and across the country in ways that I have never seen an intervention really spread. And I'm saying, using that term in a public health way as strengths and knowledge that's shared, that also spreads, not just disease, not just this darn coronavirus, but good things spread. I have seen the interventions around medicine and reclaiming our foods, relearning and sharing what our traditional knowledge of plants and medicines are, as something that has, I'm going to use the word infected our communities, injected into our communities a new life and love for learning and sharing this knowledge. And so right now we are doing an evaluation of the Train the Trainers foods network that we're seeing shared across our region here, among tribes and our urban populations. And it's really fascinating using social network metrics. And we're looking to create that map of how we're seeing these good, healthy behaviors, lifestyle changes happen in our communities, and creating a map and an image of that I now am thinking maybe we can bring in some of our local artists to really tell that story. So I'm really excited about how I get really nerdy about data and what it is and what it should be, how it can be, instead of just thinking about what I was trained as a scientist data is and should be, and how it should be disseminated or reported. I want to go back to our story really quick here. So these three siblings, they're now in foster homes. They get adopted by a foster family. All three of them, that after staying with this family for a couple of years. And they, over the years, of course, are adjusting, as well as the foster family, which is Native, to living in a world where they've learned to reject those ties and bonds in the relationship. They're still, the oldest daughter still, of course, especially, is very bonded to her Tlingit mother. unfortunately, mom passes away at a very young age. She was 41 years old. This family of 3 siblings has multiple bouts with the law, trouble finishing high school, and certainly alcohol and drugs, sometimes getting into gangs and guns. The oldest daughter, I'm going to follow that thread. And the family have more of a bond, the foster adoptive family, but it's a tenuous relationship back and forth. She has 2 sons. The oldest one is in jeopardy of going back into the foster care system. So one of the family members takes that child in more than one time. 3, 4, 5. I don't remember how many times. And that child never goes into the foster care system. But it does damage to that relationship and that what a family should be. And so you're making do with these atrocities that and assaults that have happened over and over and over again. And I want you to think now, what are social determinants of health in this story? What are they? And please share in the chat anything you've heard in this story. What are some of those social determinants of health you've heard in this story, generational story so far? Please share in the chat. I'll keep telling this story. And so the oldest sibling, she's incredibly bright. She wants to go to college. She wants to, after multiple bouts with treatment, she really wants to stay sober. She wants to be a mother. She has a really strong bond with her oldest son. And eventually gets sober, eventually goes to college. She gets all the way through with, of course, multiple bouts, struggles with alcoholism and other kinds of substances. She keeps coming back. And she gets her master's degree in social work. She still has problems that come up with, falling back into those demons that live inside her. And she is she's incredibly strong, though. She gets that from her mother. She gets that from the pieces of culture that she knows still. Colonized, living, surviving through a colonized child welfare system. Thank you. Lack of job opportunities for mother. But she's still here. That's my sister. And yesterday I was texting her. I got permission to tell her story because it's my story too. She is now getting her clinical license to help others through drug and alcohol addiction. And she's been doing that work now for the last year. This is just a story, one story. What are the resiliences and strengths you're hearing in this story? Thank you for all of those in the chat. But when we're talking about decolonizing data, when we're talking about social determinants of health, which is a very academic term, this is what we're talking about. We're talking about our own lived experiences. Does that make sense? These are our lives. So decolonize that. Tell your own stories. And use these stories and the resiliences and strengths that you're hearing in them to understand that our strengths are still here. When we look at data, we need to recognize that those strengths and resiliencies are part of what have compelled us to survive where we are today. And not just survive, but thrive. Connections made to culture. Those are some of our resiliences, to relationships, to education. You know what one of our biggest resiliences is? It's just love of our people. It's that simple. It comes out in all kinds of ways. And whatever it is that helps you recognize that and document that and tell our stories to the right audiences so that we have the resources we need to serve our communities, that's data. It's art sometimes. This image of an elder came about through a live painting, through a Pawnee artist, while he was listening to our community grantees talk about chronic disease prevention in the wake of a deadly pandemic and how they're continuing to do that work. So this image emerged from our stories. This image is data. And I'm going to stop there. And thank you so much. It's an honor to be here and with you today. And for the love of our people, love is our biggest resiliency. Any questions, any thoughts, anything anybody wants to share?